A simple topic, and I think these are the basics of calcium managing balloons. These three balloons are the specialty balloons: cutting, scoring, and OPN balloons. These are known as special balloons. I do not have any conflict or interest. Cutting balloons has 3 or 4 sharp metal microtoms. You can see in the picture, microtoms are like this: blades mounted over a non-compliant balloon which incise and score the coronary atheroma during balloon inflation. These are the cutting balloons, how it works. The specific indications of the cutting balloons are instant restenosis, classically aortoproximal lesion, especially in the saphenous venous anastomosis, bifurcating lesion, non-angulated lesions less than 45 degree, resistant fibrotic lesions. And in cutting balloons, there must be absence of thrombus. In thrombus, cutting balloon cannot be used. The equipments of using of cutting balloons: if the balloon size is less than 3.5 millimeter, 6 French catheter is okay. Then if it is more than 3.5 size, you should have a 7 French catheter. Cutting balloon, sizing of the cutting balloon should be done with an IBUS previously, and the IBUS size should be from media to media, and the ratio of the balloon to artery should be 1:1. Oversizing of the cutting balloon should not be done. Delivery of the cutting balloons it is a sharp cutting balloon. It is stiffer, so delivery might be a bit difficult. If the delivery is difficult, you can use a body wear or other devices. And inflation should be done slowly in cutting balloons with nominal pressure within 60 to 90 seconds, and deflation should be done slowly and putting the indeflator negative. In bifurcation lesion, cutting balloon dilatation should be done in the disease segment first. The cutting balloon should be sized appropriately with each of the bifurcating vessels. Kissing with a cutting balloon is almost contraindicated, as it may produce a perforation. In ISR, cutting balloon size, 15 millimeter cutting balloon is the minimum inflation, and aortoproximal lesion, cutting balloon should be used that as it does not slip into the proximal or distal part, because it may cause dissection into the vessel. Contraindications of the cutting balloons are: avoid passing through the stent stud in the previously deployed stent, avoid lesion in the thrombus. In bifurcation lesion, cutting balloon can be used prior to placement of the stent, but not after placing the stent. This is the case where there is an osteoproximal lesion with an anomalous RCA calcified lesion, wiring done, and the pre-dilatation was done with 2.5 into 10 millimeter NC cutting balloon, and dilated up to 12 atmosphere. Then 3 into 21 millimeter drug-eluting stent deployed from the ostia of the RCA, anomalous RCA, and this is the final result. Now the scoring balloons. Scoring balloons consist of double lumen catheter with a non-compliant and semi-compliant balloon surrounded with an external Helician scoring edge. It is a dual wire balloon, a scoring balloon, and short rapid action tips facilitate to combine effect. Indications of the scoring balloons are calcified and fibrotic lesion, osteal lesion, bifurcating lesion, long diffuse lesion can be used properly, and in small vessel. In instant restenosis, scoring balloon may be used. A special consideration of the scoring balloons are: it has a good trackability and good flexibility, so can use in different lesion where it is needed. Different from cutting balloon, the scoring balloons is less non-compliant, so that at high pressure, its diameter tends to increase. And it should be used at a cutting balloon at the undersizing with 0.5 millimeter. This is an octogenarian patient with an class 4 angina having a calcified lesion in the critical distal left vein, proximal LAD and proximal LCS calcified. Pre-dilatation done from left main to LED and LCX to 2.5 into 10 millimeter scoring balloon. After scoring balloon dilatation, the first dilatation, again pre-dilatation done with 3 into 10 millimeter NC scoring balloon. And final result, the lesion was managed with a tap technique, and this is the stand beach on the last fixed picture. Opium balloon are very high pressure balloon. It is a double layered balloon with a minimal dog boning effect and is optimal resistant to deformation and guarantees preserved balloon diameter even at highest inflation. The balloon can be inflated up to 40 atmosphere. Maximum balloon are 40 atmosphere nowadays. Previously it was 30 atmosphere. And for the inflation, the separate device is needed, and which is a costly device. And characteristics of this opium balloon is these are the tiny layered balloon constriction, virtually zero dog boning effect, high pressure PTCA balloon, rated brush pressure is up to 40 atmosphere. It is a good trackability and good crossability. Minimum 6 French catheter can accommodate the opium balloon. These are indicated in highly calcified lesion, up-dilated lesion, in combination with the rotablation. After rotablation, if the lesion is not well dilated, opium balloon, as our panelist was saying in the previous live case. In the live case today, successful treatment in instant restenosis. This balloon, pre-dilatation of the treatment in instant restenosis, opium should be sized at 5 millimeter smaller size than the reference vessel. IVUS should be done before using an opium balloon. It should be inflated slowly, 5 atmosphere in every 10 to 20 seconds. Use supporting guide wires may be taken, as our panelists were saying in the live case. It can be used. In under expansion of the stent, in case it is very often used in under expansion of this stent, and imaging should be done before using a scoring balloon. This is a case in our center. We do not have opium balloon at present, but we have done a workshop with an opium balloon. This is from the workshop. It is a calcified lesion in the left main to LCX. And NC balloon taken, lesion did not get. Opium balloon taken, pre-dilated with lesion and went up to 35 atmosphere. And after that, the pre-dilatation of the opium balloon, a stent deployed, and this is the final result. So this is the important graph showing that when to use these specialty balloons. In calcified lesion, both cutting, scoring, and opium balloon can be used. In calcified nodule, opium balloon is almost cannot be used, and calcified nodule, there should be IBL or a rotablation done, because the scoring balloon and cutting balloon has minimum effect. In fibrotic lesion, cutting balloon is most important, and opium balloon has little effect. In under expansion of the stent, and opium balloon is a classical, and in instant restenosis, cutting and scoring balloon is an of the choice. I highly acknowledge Professor Fazila Malik Madam for preparing this lecture. Using of cutting, scoring, and opium very high pressure balloons have dramatically changed the modern approach for the operators in angioplasty. The use of cutting, scoring, and opium very high pressure balloon can raise the better PCI outcome in selected cases, especially in combination with intravascular imaging. In fibrotic lesion, cutting balloons are more favorable in lesion preparation. Stent under expansion, opium very high pressure balloon is the choice. The design of the scoring balloon favors a controlled and uniform balloon inflation, thus minimize the risk of balloon slippage. Thank you from our cath lab team. Thank you for all for patience hearing.
Thank you, sir. It is a brilliant presentation.